Okay, good afternoon, everyone. I think we will make a start. It is bang on midday. A very, very warm welcome to all of you. My name is Dagni Rajsingham. I'm Deputy Chief Medical Officer at Guy's and St Thomas's and Medical Director for Secondary Care Transformation in NHS South East Region. Thank you to all the regional colleagues and non-regional colleagues who are joining. And I just wanted to say that I know that it is turbulent times. Many of you will have been on the briefing, but actually that maybe the timing of this session is even more pertinent because it is work like this, it is frailty, flow and the left shift that we need to be focusing on in order to ensure the sustainability of our NHS. I'm going to hand over to John, who is CEO of the Institute of Health and Social Care Management, to do a brief introduction and then we will get on with the session. John.
John, you're on. I can't believe I've done that after nearly 6 years of dealing with Teams and goodness knows what else. Big moment, and I blow it by being on mute. That's £10 in the charity box. Welcome, everybody. I'm absolutely thrilled for the Institute of Health and Social Care Management to be hosting this really rather important event. Dagni, you know, has done a splendid job and will be chairing as we go along. We have some stellar guests who are going to be presenting throughout this, and all I can offer is my unqualified support to everybody involved in the whole business of frailty, left shift and flow. I wish you all well. Thank you for your attendance today, and I'll hand straight back to Dagni. Thank you.
Thank you very much, John. Please could I ask people to use the chat, keep your comments, conversations, reflections. This isn't purely about listening and learning. It is also, I'm very, very keen that the collective wisdom of everyone on this call is captured. We will be recording the session, so it will be available. I'm going to hand over to Professor Jugdeep Dhesi. She's a colleague of mine at Guy's and St Thomas's, and even more importantly is president of the British Geriatrics Society, and she's going to give us a short introduction to the national landscape and the left shift. Over to you, Jugdeep.
Thanks so much, Dagni, and thanks for the opportunity to speak to everybody today. As you say, very turbulent times at the moment, and a real need for us to be looking at all the things that we can do collectively to continue to have our sustainable NHS for the future. So I think as a geriatrician, if we do go to the next slide there, thank you. I think it's always really important for us to celebrate the successes of health and social care over the last 75 years or so, where we have seen our population pyramids now become population columns pretty much. With now kind of 1 in 5 people living above the age of 65 amongst our communities. And of course, in health and social care, we don't see everybody out there who are living full, well lives, enjoying all kinds of things. And I think it's really important to acknowledge that we only see, a proportion of older people. And there are lots of people doing all kinds of amazing things out there in our communities. If we go to the next slide. But of course, what we do know is that with aging comes health-related problems, and we know that about 10 years above the age of 65 are lived with health-related problems. And if we just click there again, and of course that's not surprising, because if we look at the main pathological processes that kind of occur in our population, whether they're metabolic, degenerative, neoplastic or cardiovascular, all of those processes happen increasingly with increasing age. So we see kind of all of these kinds of comorbidities happening more frequently as people get older. And if we go to the next slide. And of course that means, and if you just click there again, thank you. What that means is that actually the population pyramids aren't so interesting to us in health and social care, but these other pyramids that show us what happens in health and social care are much more important. So you can see here with the table on the right that it's older people who present to our health and social care services. Of course, women of childbearing age and kind of babies and young children. But you can see actually we're now looking at a funnel when we look at the population pyramids presenting to health and social care. And that's really apparent in lots of the data when we compile all of the different reports, showing us that if we look at all of our people out there aged over 65, about 1 in 3 of them are on a waiting list for something, whether that's diagnostics, a medical intervention, or a surgical intervention. If we look at our front doors, then 40% of adults presenting to ED departments across the country are aged over 65, and 66% of our hospital beds are occupied by older people. The other really important thing there is that 1 in 7 of people who we do discharge from hospital actually are readmitted within 28 days. So there are things that we need to be thinking about for the population at the time of discharge to avoid that revolving door that's otherwise seen. And really importantly, with all of the kind of discussion at the moment, prompted by the Assisted Dying Bill, the End of Life Care Commission, we know that 1 in 3 people in hospital are in the last year of their lives, and we're spending £22 billion on that last year of life. So this is a really critical thing for us to be grasping if we're going to have a sustainable NHS for the future. Just click to the next slide. The issue with older people is, of course, it's not just the numbers. We know that increasing numbers are seen across the system, but this group comes with a lifetime of accumulated issues. So we know that a fit 80-year-old isn't the same as a fit 30-year-old because there is physiological change with aging. But then once we add in socioeconomic determinants of health, which account for at least 80% of people's health status, that, of course, has a greater impact over time. So smoking or alcohol dependency, poor housing, poor nutrition, all of those issues that can affect both health status and health-seeking behaviours. And then we have the issues around multiple long-term conditions and frailty, things that we're going to focus on in the next hour or so. And if we go to the next slide there. And so some of those issues are kind of really tell us kind of how our older population are living with complexity. So if we're looking at those wider determinants of health, about 1 in 5 people aged over 65 are living in poverty. We know that almost 3/4 are overweight or obese. And we've done really well with smoking, but still 1 in 12 people aged over 65 are smoking. And we've not been doing so well in terms of activity. So let alone trying to get people to exercise, around about half of our older population is physically inactive. That means less than 30 minutes of physical activity 3 times a week. And then we add in things like social isolation. We know that all of this results in inequalities, whether that's inequalities driven partly by socioeconomic status, by age, by multiple long-term conditions, by frailty, and that it's these groups of patients who do wait longer for intervention, and when they do receive treatment, have higher complication rates. And just click there again. And that's really even before we start to look at the issue of multiple long-term conditions, which Nigel is going to be speaking about a bit more in detail. But half of our older population are living with multiple long-term conditions. This kind of has all kinds of implications for that population. Not only are they being referred to multiple specialists and then patients having to navigate their way around different teams, arranging transport, arranging someone to go with them, but it also means that this group are more likely to have polypharmacy. So we know 3 in 10 older people take more than 8 regular medications. And we know that adverse drug reactions result in admissions and particularly in readmissions. So all of the issues that are raised by polypharmacy within this population who are living with multiple long-term conditions. And if we click there again, and then we've got these added other syndromes. So it only just becomes more complex. We start off with these socioeconomic issues. We start add in multiple long-term conditions, and then we have geriatric syndromes such as frailty, with a lot of older people living with this syndrome of frailty, which is calculated to cost around about almost £6 billion to the healthcare system. Adding in mental health issues, and then of course cognitive issues such as dementia, which is becoming an increasing issue for our population, and so much of that cognitive impairment being unrecognised in this population because we put it down to being part of normal ageing and don't do objective assessments to be able to understand the scope of the issue. And if we click to the next slide, we know that this group, not surprisingly, then has worse outcomes, whether those are clinician reported, patient reported, or process related. And we see that at hospital level data, where hospital acquired complications occur most frequently in this population living with complexity. But we also see that in national audit data presented by HQIP and through inspections such as the CQC inspections, and of course with complaints and coroners that get picked up by our ombudsman. And if we click to the next slide. So it's clear that we do need to have a system level approach to support older people. And really we've got to get it right for older people if we're going to get it right for the NHS, considering they are the biggest user group of health and social care. So we do need to support our population now, starting with a life course kind of approach to it, to ensure that we future-proof the health and social care sector for tomorrow's older people. And that's where the primary prevention work really comes into play. But then at the same time, we do need to rise to the challenge of supporting older people to live well now by addressing the needs that they have through proactive or anticipatory care. Kind of, in some ways we could call that the secondary prevention part of our work. And a lot of this work's being done through the British Geriatrics Society, and I've just illustrated that with a couple of reports there at the bottom. And the next slide. So that primary prevention work is going to kind of be looking at those shared risk factors for multiple long-term conditions and frailty, the things that we know a lot about already. And we don't need much more evidence to tell us that these are the things that we need to be focusing on. But what this does require is a policy change, not only at health level, but also at education, housing, work and pensions. And those are the kinds of initiatives that we've been working with the Faculty of Public Health and with Chris Whitty in the Chief Medical Officer's office to be looking at those aspects. And then to the next slide. Leading us on to secondary prevention, and particularly of frailty, but also of multiple long-term conditions. And of course, it's really important to be proactively identifying frailty so that we can put in proactive measures to avoid progression, to avoid crisis presentation, make sure we're delivering care in the right place, and that that's supported through a personalised care approach with embedded shared decision-making. And Lucy will be talking a bit more about this later. Go to the next slide. I think the important thing here is actually we've got so many of the resources between us all, and certainly we've tried to collate a lot of these at the British Geriatrics Society website through the Frailty Hub and other resources as well through GERFT and NHS England. And there's been lots of work at kind of designing our kind of vision for the future, the strategy that needs to be undertaken. But at the same time, we now need to start to implement this. And this is what we'll be talking about shortly. If we go to the next slide. There is still lots of variation. And again, that's where the GERF data really helps us to be able to work out where we're at locally by looking at some of those outcomes. Clearly, we need to make sure we have co-production with our patients and the public in designing these services, but actually all of those studies so far tell us the same things. And these are some of the things that I've listed here that we repeatedly hear when we're doing co-production work. So I think we do need to move on now from asking people what they want to actually starting to deliver it together with them. And moving to the next slide. So what's needed? Well, I think we do need leadership, and that's why it's so great to have this webinar. We need to be developing policy that's attuned to the needs of today's healthcare users, which is really different to when the NHS was set up, when we had a single condition or a single organ approach. That needs to lead on to commissioning of patient-centered services rather than condition-specific approaches. We need to look at some really radical disruption across boundaries. And again, Tanya and Lucy, I'm sure, will be illustrating that. We've got to adapt our workforce to support people who are living with complexity and be looking at that cross-boundary working, which requires integration across health and social care. And that also needs to be underpinned by supporting our public to understand as well what's needed when you're living with complexity. We need to address what matters to them, but that does have to be through evidence-based and cost-effective initiatives. And then the last slide, I think, which kind of is just a kind of little plug again for the British Geriatrics Society, where we have been working really hard across organisations, certainly at the Department of Health, with NHS England, Scotland, Wales, Northern Ireland, looking at the workforce approach, but also with measurement and regulation bodies to make sure that we are measuring the right things that help us to be able to then deliver services that are required. So that's a little bit of the background around kind of where we're seeing things on a general kind of basis. I'm happy to take any questions, but or Dagny, if we want to take questions after the next presentations, then that's fine too.
We have time for maybe one or two questions. If you want to just pop your hand up, and Jade and Julie, if you don't mind keeping an eye. Whilst people are thinking, Jeff Berg did put something in the chat saying that unfortunately we're seeing a disinvestment in the NHS commissioning of VC voluntary sector and a de-emphasis in terms of proactive and preventative measures. So really a very important comment, Jeff, and I think I put that, I agree, and I think Jugdeep probably does as well. Could we come to you, Olivia, for your question?
Yeah, certainly. Thank you. Apologies for joining late. I'm Olivia Clymer. I'm Director of Strategy and Partnership at Oxford University Hospitals, but I confess that I was the Chief Executive for Health Watches in Central London for 5 years. So I would just want to echo what you've been presenting on and that need for co-production and the value in communicating to our patients and the families around them to understand this. And I think we did some work on long-term conditions when I was at Health Watch, and very much about, you are not a series of conditions, you are a whole person. And empowering our community to be able to support and do that and be active participants in their care. So I just wanted to echo it and thank you for the presentation. Thank you.
Thank you, Olivia. Jeff, did you want to come in?
Yeah, please. Thanks for that, Jugdeep. Just wondered if you could say a bit more about capacity within primary care and community services. I know we've got great examples of geriatricians working in the southeast in London, but obviously an area we want to expand on.
Yeah, and I think that's so important, Jeff. This is a collaborative approach that's required, isn't it? And just yesterday we had a meeting with the RCGP to start to look at how we can support general practice colleagues to be able to identify people living with complexity using population level data to then ensure that we're aligning the right team to the right individual. And I think some of that will come out in Lucy and Tanya's presentation as well, is around kind of how we start to segment the population, much in the way that we've done in the surgical setting. We've got the high volume, low complexity group of patients who go through the surgical hubs, and then we've got the higher complex kind of but lower volume group that you want to really be having a focused approach to. And this is a similar kind of approach that we can take here around how we use population level data, segment the population, but of course that then requires upskilling of teams to be able to deliver that. And hopefully that's going to, depending on what happens with NHS England's kind of work and everything else that's going on at the moment, maybe the integrated neighbourhood teams approach may be the way in which we can coalesce some of this work. And then there's potentially, if frailty collaborative kind of piece of work coming from NHS England too. So it's just at the moment how we align all of these pieces of work, which, you know, there's lots going on, but we need to have a consistent approach between all of us to ensure that those messages are getting heard appropriately by the policymakers and then commissioned, not decommissioned, as you've rightly said there.
Thank you very much, Jugdeep. I'm going to come to John, but just want to reiterate that point, Jugdeep. There is so much that happens that is excellent and really good across the NHS. Us coalescing and therefore maximising impact is maybe where sometimes we miss a trick. So again, my thanks to IHSCM for allowing us to breach one of those boundaries between South East London and South East of England. John, your question.
Thank you, Dagny. I'm just conscious of the fact how few of our colleagues from social care are on the call today. Quite understandably, a lot of NHS people, but it strikes me that this collaboration between social care providers and health, if we can call it that, is just critical to this. And I wonder whether you have any sort of quick wins that from a BGS perspective you'd be advocating we embrace.
So John, I mean, it's a kind of perennial kind of discussion, isn't it, around kind of people. So essentially, I don't think that we can disentangle health and social care when it comes to older people. One causes the other causes the other. We have to bring the two things together to be able to effectively support people to live well in their communities, avoid unnecessary hospital admissions, but ensure access to hospital treatment when it's necessary. So we have to bring the two together. So we're doing some work with 5 ICBs from the British Geriatrics Society dotted around the country to start to share their vision documents, their strategy documents, but also the resources that they've developed to implement this into clinical social care practice. And that's got to be our route really at the moment, doesn't it, for kind of bringing together health and social care. We don't have a mechanism other than the ICBs at the moment. And I think, you know, Tanya and Lucy will be discussing some of those boundaries and how we can overcome them. So there will be stuff coming from the BGS this summer. We're hopefully going to develop a resource pack for ICBs that can then be shared. And of course, we'll share that with you for wider dissemination too. Or you're on mute, Dagny.
Sorry, thank you, Jugdeep. And just one other comment in the chat around standardising templates, really, care plan templates, which you might want to type into the chat. That was just a question for that. Thank you very, very much. I am going to move on to Tanya Kelsey.